Good afternoon, everyone. This is Sarah Ryan at OTSG, and today we're going to present an Aspire series on Manpower 101, Manpower Models and TDAs. Our presenters today are Dr. Mark Perry, the Chief of MedCom Manpower, and his right-hand man, Lieutenant Colonel Mike Nagra, who's the Chief of the Clinical Models Division. Thank you for joining us. Please sign in on the attendance roster in the bottom pod within the DCO. And again, if you're on the audio, please remember to mute your phones if you're listening in on the audio bridge. Very important for our recording. With that, I will turn it over to Dr. Perry and Colonel Nagra.
Good morning/afternoon, everybody. This is Mark Perry, and Colonel Nagra is here with me. We will be talking about, we've been asked to discuss manpower today, and for many of you, this is something you may have done for a while. For others, this is a bit of a new concept, and as we go through this, you're going to find that some of the rules that have been applied in the past are changing, and we will go through some of those things and talk about the changes in the way that we're going to be doing manpower moving forward. You have the slide deck that you can see in front of you in the shared portion there, and so I will go ahead and start. Our agenda, we're going to talk about a number of different issues. We'll talk about concept plans, manpower studies, manpower models. Then we'll get into some programming issues, which is how we talk about manpower throughout the POM period. We'll talk about how we document the TDAs and how often we update those. And then we'll get into some issues about how we validate the requirements on the TDAs. And then we'll provide some examples about some of the manpower model building that we have done in recent months, and answer any questions that you might have about some of the models that are currently being reviewed and approved at the headquarters DA level. So moving on to the next slide. First question is why we have to do this, and it really is based upon a number of different requirements. Title 10 U.S. Code Section 115A talks about how Congress requires the DoD to submit an annual manpower requirements report that talks about how many manpower requirements are required across DoD, and of course we are part of that. The DoD guidance is in 1100-4, and that talks about manpower requirements being driven by workload, and that they will be established as the minimum essential levels necessary to accomplish the mission. You'll notice that minimum level does not mean the optimal level. It's a very different requirement. It's the minimum level required to accomplish the mission. And before we can change any of the manpower requirements, there have to be changes in programs, missions, and functions that require those resources. And then finally, we go from the DoD instructions down to AR 570-4, which is the Army's set of rules for how they apply the DoD instructions and the Title 10 law. And so these are the guidelines and the rules that we have to follow in order to appropriately document our manpower requirements and authorizations on our TDAs. Now there are a number of different ways that we can, moving on to the concept plan slide, there are a number of different ways that we have to document manpower requirements. Oftentimes we have a new mission, and there are out there, and many of you may have met this individual. There is somebody I like to refer to as the bright idea fairy, that kind of floats around and likes to hang around people with senior rank, be it colonels or general officers, and whisper things into their ear that say, wouldn't it be really great if we did fill in the blank, okay? And it's kind of a new mission oftentimes, and they are really great ideas that we need to talk about how we're going to proceed forward to do that. And when we have those really great ideas, we need to document. It's oftentimes a new mission. It's something we haven't done before. You know, you may have heard about the NICO satellites, for example, or or something where we're going to do something really cool for a group of our beneficiaries, soldiers that have been injured and have polypharmacy issues and traumatic amputations and all kinds of different things going on. We want to provide an integrated means of caring for them that kind of breaks the mold, so to speak. And so when we have one of those new and interesting ideas, the way that we document the manpower requirements associated with that, because we don't have any historical workload to apply to it, is we do something called a concept plan. And a concept plan is required whenever we have a new mission or are reorganizing our assets in such a way that new manpower requirements are going to be generated due to documented mission changes. Now, the concept plan's point of contact is Dee Garza, and there's her telephone number there. Some examples of concept plans that we've done in the past few years include the CONUS RMC/Regional Dental Command concept plan. That's how we ended up with the RMC headquarters that now have about 168 or so manpower requirements versus the original RMC headquarters that had 12. And so when we did that concept plan, we identified and we requested about 182 requirements that when they were reviewed by the Department of the Army, they validated about 168 or so. And so that's what we have on those TDAs. In the RMCs and CONUS is about 168. The regional dental commands are part of that. It's the same concept plan, but it's a slightly different number of requirements for the regional dental commands. And then we also have an OCONUS RMC concept plan that's still being generated, and it looks like it's going to generate requirements for about 134 or 35 manpower requirements, slightly different because of the different roles that we have in OCONUS versus CONUS. And the OCONUS regions tend to be a little bit smaller in terms of the number of facilities that they have to manage. A couple of others that you may have heard about is the Office of Soldiers Council. This is where we are organizing the legal support for the soldiers who are going through the MEB-PEB process. Some of that legal support currently exists within the WTUs, but we're going to reorganize it and put it into something called the Office of Soldiers Council, where the attorneys will not be under the direct control of the MTS commanders because it presents currently a conflict of interest. If the attorney is assigned to the organization where they're representing the soldiers, and what has happened in some cases is the commanders of the organizations have been tempted to use the attorneys to help them process Article 15s and so forth. And for those of you who've been around the military a long time, you know that the Trial Defense Service is separate from the prosecuting side because of the conflict of interest. And this is sort of the same situation. The attorneys that are in the WTUs are there to represent the soldiers, not the commanders. And so in order to make sure that that happens, we are reorganizing that structure and taking it out from underneath the hospital commanders where they might be tempted to have a conflict of interest there with regards to who they represent. JTAPIC is the Joint Trauma and Amputee folks, and that has gone in and been approved and is about to be documented. And then we have another concept plan that was generated recently for the healthcare acquisitions activity. And so these are examples of new ideas, new growth, things that are different from what we've done in the past, and we don't necessarily have the workload associated, the historical workload for it, that we've generated a new concept plan. Slightly different from a concept plan, but very similar, is something called a command implementation plan. We use this one when we are going to do a reorganization that does not result in new manpower requirements. An example is when we organized the Public Health Command, what we really did was we took the VETCOM and CHIPO and we merged them together, and we did not increase the number of requirements, we just put them together on one document. And so that's what we did with Public Health Command. We just put the two together, and there was no increase. It was just, the two organizations got merged together. Another example will be the headquarters MedCom bottom-up review. There's several phases of this. We'll talk about studies a little bit later, but the first phase of this was to reorganize existing staff into a G staff. So some of you are familiar with the fact that we now have a G146 and a G357 and a G89. And what we've basically done is take all the old assistant chiefs of staff positions and we've merged them together, and that's an example of a SIP. And so that has gone into headquarters DA, and we're awaiting approval to document that. So again, command implementation plans and concept plans are when we're going to just reorganize with or without new requirements. Now, Manpower Studies is what we use when we are looking at a unique organization. And when I say unique, I mean there's nothing else like it in the free world kind of a deal. So the AMED Center and School, for example, is a unique organization. It is the only one of its kind. And we don't have, 5 of them to compare to one another. We just have the one. And so a Manpower study, you may have heard in times past there was something called Manpower surveys and so forth. And this is kind of the same thing. We go out and we look at each work center, and when I say work center, think of a paragraph on the TDA. We will go and we will look at the workload and the time associated with that workload in each work center and to try to validate it. So it requires a very labor-intensive process where we send individual management analysts out to interview people and to talk with them. Prior to those interviews, people fill out forms where they kind of document what it is that they do, and then we go and validate that workload. And then when we have finished all of the validation, we send it in to the U.S. Army Manpower Analysis Agency, and they review it, and they will pass judgment on it. And if they agree with us, then they give us those requirements, and if not, then they will say, well, we'll give you, 3/4 of them, or 9 out of 10, or whatever. And these are the positions we don't think you justified very well. And then it goes into a reclama process. We go back and forth and argue and try to defend the organization's honor and their manpower requirements, and it kind of goes back and forth. It's a very, very labor-intensive process. So we only use this for unique organizations. The ones that we primarily use this for within MEDCOM are the AMED Center and School, MRMC, the MEDCOM headquarters, specifically, when we have to revalidate the total requirements, and then the Public Health Command is another example. We would also use it for things like USAMIDIC, U.S. Army Medical Information Technology, and that other unit that we have up here at the headquarters that manages all of our IT infrastructure. So that's what we use Manpower Studies for. And so oftentimes we'll get a request from an MTF out there that says, hey, we want you to come study our organization. And our response is, you're not unique. And they say, well, yes, we are. We're unique. You can pick the hospital du jour that believes that they're unique, whether it's Walter Reed or Fort Hood or Fort Bragg. And they are unique in that they have unique populations to serve. However, they all provide very similar functions, and not always the exact same. But for example, if you're going to look at even a function that is not provided everywhere, like vascular surgery, we don't provide it in every place, but we provide it in enough places where we can look across all of those places and identify what's the proper way to do the staffing. And that brings us to our next slide, which is Manpower models. Now, if we have a function that is performed at multiple locations, whether it's a clinical function or an administrative function, and it's done at the same level, same tier, and it's done across many organizations, and then we use models to identify the appropriate level of manpower requirements associated with those particular functions. And it includes both clinical functions and administrative functions. So our MTFs are in this category where we have lots of medical centers, we have lots of MedAcs, we have lots of clinics, we have lots of dental treatment facilities, et cetera, and even the veterinary treatment facilities. When we look at that particular part of Public Health Command, we can use a model to identify what the staffing should be. Some of the examples that I've listed down here include logistics, medical libraries, primary care, and behavioral health. And there are some others that we will address that are kind of representing some additional things. Now, if we think about how you would do logistics, for example, you've got several different functions within logistics. So you've got the property book function that, you got to keep track of all the hand receipts. And we got to identify how many people you need to run the property book and put out all the hand receipts. And you got to identify on the medical maintenance side how many maintenance work orders we have and how much time it takes to get all those pieces of equipment maintained. On the linen management side, we got to figure out how we're going to launder the linen and redistribute it to, we got to pick up the dirty linen and cleaned either in-house or sending it out to a laundry facility or to the VA. And then we've got to bring it back and get it redistributed. You know, all of those logistics functions require manpower to get that done. So in our logistics model, we have a lot of different categories that are in there that even include the housekeeping staff and all the stuff that goes into logistics. Medical libraries, you know, most of your facilities have a medical library there. Well, you kind of wonder, well, how do you determine how many librarians? Well, the librarians are basically predicated upon the number of staff in the hospital. So how many doctors and nurses do you have that might have need for a medical library? And so the staffing numbers are based upon there's a library association that espouses, puts out ratios of what you need for medical libraries, and that's what we use to generate those kinds of manpower requirements. In primary care and behavioral health, we have two models that are currently documented on our TDA. The primary care model as it currently exists is predicated upon enrollment and utilization of our primary care for primary care providers. Sarah was one of the people who helped work on this originally, as well as the behavioral health care model. These two models are slightly different in that the behavioral health care model looks at our productivity, whereas the primary care model currently in use looks at the number of clinic visits that people generate per week. And so when we were looking at these two models, we said, you know, there's probably a way to kind of merge them together in a way that would be useful for all specialties. So we'll talk a little bit later about the new professional services model that actually gets into that kind of a methodology that we are going to be using for all of the clinical specialties. So I'm going to depart now and go to the Manpower programming side for a few minutes. Now, some of you have seen TDAs enough to know that there's something called requirements and there's something else called authorizations. And generally speaking, the authorizations are less than or equal to the number of requirements. The definitions are this. The manpower requirement is, as we said before, the minimum essential number of FTEs it takes to accomplish the mission. So why would we have an authorization, number of authorizations that is less than the minimum essential number required to do the mission? Well, it's a good question. I can't really answer it except to say that the authorization represents the authorization to actually expend money to hire somebody or to assign a military person to that particular function. And so when we get into a resource-constrained environment, the authorizations are reflective of the resource constraints on the manpower side. So in an unconstrained world, you know, we could have all the authorizations we needed, and we could have everything we wanted to do all the missions, and there would be no conflicts there. But as you all know, and especially under the current environment of fiscal uncertainty, we do have a constrained number of resources, and so the authorizations are becoming more and more important in these decisions. Now, to do the programming, we programmed the number of authorizations not just for the current year or for the TDAs that have been published for this year and the next year, but we look at over the entire POM, and we forecast those authorizations and requirements out over the future. And we are dependent upon headquarters DA to direct us in terms of a lot of those authorizations. Now, authorizations can only be placed against a documented requirement. So if you think about it, it's sort of like placing a car into a parking space or a hand into a glove. You've got to have a place to put the authorization. You can't just have the authorization separate from some sort of requirement. And once in place, the authorization serves as the documented authority to assign a military person or hire a civilian or a contract employee to perform that validated function. Katie Rosen is our point of contact there. She's been doing it for a number of years, and she's really good at it. But I got to tell you, there are times when the Army comes down and says we have to do certain things. And one thing that you're going to see on the TDAs for fiscal year 15 is that headquarters DA has directed that all of the unresourced requirements on the TDA, whether they're military, civilian, or contract, and by unresourced I mean that there is no authorization on them. They want all of them removed from the TDA, effective 1 October for fiscal year 15. And so we've been fighting against this, but it's not our rules that we have to play by. We have to play by the Army's rules, and the Army makes that decision. And so when we get down to 1 October of 2014, about 18 months from now, you're going to have a TDA that for one day at least is going to be really, really whack, just because all the unresourced requirements will come off. And then for the subsequent TDAs for fiscal year 15, we will be applying additional models and so forth that will put some of those requirements back on after they've been removed. And so we'll talk a little bit about why the Army is doing this, but it has to do with trying to force everybody in the Army, and not just the MedCom, into a requirements equals authorizations kind of a world. And the way that they try to do that is by eliminating requirements that are in excess of authorizations. Okay? But we contend that we need to have those extra parking spaces, so to speak, those extra requirements, so that we can move authorizations from place to place when missions change. And when we need to do things like optimizing a particular corps, and you need to optimize where you're putting your military versus civilians so that the military can get all the training that they need at the bigger platforms. An example is when we look at intensive care nurses, for example. We have ICUs at lots of different places, and some of those places don't have really robust care going on there, and so the ICU nurses aren't getting the experience that they need on a daily basis, so that when they get deployed, they're up to snuff in terms of the recent experience in taking care of intensive patients. And so, the Nurse Corps wanted to realign where they put their military ICU nurses, and they want to move them to places like BAMC and Walter Reed, where the ICUs are actually full of, lots of very, very sick patients, and the nurses can get that experience. And so, in order to do those kinds of things, we need to have requirements that are out there that we can move the authorizations to, so that we can reassign the military. And so our contention is we need to have some of those extra parking spaces in the parking lot so that we can move stuff around as the case may be, as may be required. Now, once the programming is done and has been forecasted throughout the POM, we then have to match the program with the actual TDA documentation. And so the requirements and authorizations are documented on an organizational table of distribution and allowances. We call that a TDA, and those are approved and published exclusively by Headquarters CA. So within MedCom, we do not get to publish the TDAs ourselves. In fact, we do not get to approve those requirements or authorizations ourselves. It is all done at the Headquarters CA level, and we basically have to play the mother may I game with them and get them to approve everything that we want to have done. Sometimes we're successful, sometimes we're not successful, but it's a never-ending challenge to try to get what we need for our patients and for the MedCom. TDAs can be updated and modified each fiscal year to reflect the initial changes in the POM, as well as changes that are associated with Headquarters-approved concept plan studies and models. So, for example, we have an 01-14 TDA. That's the first TDA for fiscal year 14 that's been published, and we're in the process of publishing the 02-14 and the 03-14 and so forth. Each time you publish a subsequent TDA for a given unit, the serial number, so to speak, the CC num, as we call it, goes from 01-14 to 02-14 to 03-14, and the effective date of that change will be backed off 1 day for each subsequent change. So your 01-14 TDA will be effective 1 October, the 02-14 will be effective 2 October, etc. And they can go on into mid to late October. Sometimes they'll even have something that's effective as of January 1st or a quarter later. It'll be, the 05-14 or something, and it will have an effective date that is sometime later. Now, The thing you need to remember for the human resources side is that only the most current change within a given fiscal year should be relied upon as the authoritative document. So once the 0214 or the 0314 or the 0414 is published, that becomes the ruling document for identifying who you can hire and who you can assign, how you can assign military people to a position. So the 1 October document is not usually the one we actually end up using. It's usually one of the, the 02 or the 03 or the 04 in any given fiscal year as the most current one as of the E-date. And even though it has an effective date after the 1st of October, we just sort of pretend that they're all effective 1 October, really. But headquarters DA has to separate the effective dates, by 1 day, but it doesn't really mean that they're not effective on the 1st of October. It's just kind of a housekeeping rule that they use. All right, now our point of contact for documentation is Dr. Shaw. Now, when we talk about requirements validation, we're going to go through a number of issues here. AR 570-4 specifies that Manpower requirements will be validated and approved at the minimum essential level based upon workload documented in authoritative systems. So what that means for us in the MedCom is we look at the big systems that we have developed over time for the military health system that documents our workload, our time, all those kinds of things, and we end up looking at ALTA and Demersai and MEPRS. These are authoritative systems. They're operated by DoD and the Army, and we use them to document workload. Now, this data is stored for each MTF in the MHS data repository, sometimes called the MDR, and the M2, which is the MHS mark. Now, the U.S. Army Manpower Analysis Agency is charged with validating and approving or disapproving all of our data, the concept plans, the studies, and the models developed within the MedCom for manpower purposes. So this organization does not consist of people who are familiar with healthcare. And so what we have to do is teach them about healthcare data and how it's gathered and what it means. Some of you are familiar with the concept of RVUs or DRGs. We have to teach them what an RVU means and how it can be used for manpower purposes. So and they consist mostly of management analysts and operations research specialists who have experience with things like Lean Six Sigma and operations research models and simulation and things like that. And we will use those tools when we have to and when they make sense for the MedCom. Once USIMA has validated our data, concept plans, studies, and models, and the requirements generated by them, then we have to take those results that are approved by USIMA and get final approval from headquarters DA in order to document the TDAs. Okay? So there's a lot of different people who have a hand in this pie, and it used to be the truth about prior to 5 years ago, MedCom had the authority to approve the models and to document the TDAs. Each of the MACOMs had that authority in years past. About 5 years ago, however, the Army made the determination that the MACOMs were abusing the privilege, and some of them were adding requirements to their TDAs that were not really valid. And so, based upon that, the Army decided that they were no longer going to allow the MACOM commanders to have that flexibility and that approval authority. And so they withheld the approval authority, so now the MedCom commander and OTSG do not have the ability or the authority to identify manpower requirements anymore or to approve them. And so one thing that we need to make sure everybody understands is that while the Surgeon General can sign off on the op orders, for example, that talk about patient-centered medical home or soldier-centered medical home or any of the things that we say that we're going to do, she has the authority to direct us to do it, but the manpower requirements associated with those op orders are outside of her approval authority. And so when we get those op orders and so forth, we try to, we then have to go and convince G357 that those manpower requirements that are set forth in those op orders are valid. And sometimes they agree and sometimes they don't. And so what we have tried to do is when those op orders are being staffed, we try to remove references to comments that say this is what how you will staff this, if it leads people to the belief that because we're doing, pick one, EBH or PCMH, et cetera, that we will get new manpower requirements associated with this particular function. In actuality, what we do is we earn the manpower requirements based upon workload, and then the commanders can task organize the requirements that they have earned into those work centers for EBH or patient-centered medical home, et cetera. But they have to be earned in accordance with the models that are approved by the Army. Now, we're going to go now into some model building examples of how we do some of these things. There's three major types of clinical models that we use. The clinical models, and we'll talk about the professional services model momentarily. They are based upon projected RVUs and PBAM RVU targets by clinical specialty. Now, when we say projected, what we do is we look at the utilization rate in terms of RVUs for a given population at a given MTF within a given specialty. And then we look at how the population is supposed to change going forward. So some of you are aware that the Army is going to be downsizing, and we're going to be reducing the number of BCTs and increasing the size of some of the BTCs. So some places might grow a little bit, other places will shrink a bit, and the population supported at each MTF will change. Well, the utilization rate is probably not going to change. If you take a soldier at Fort Bragg, it tends to be a very young, healthy population for the most part, who jumps out of airplanes and gets banks up their knees and ankles a lot. And so the utilization rate in orthopedics, for example, at Fort Bragg is probably not going to change much in terms of the total population or the per capita utilization. So we take that per capita utilization by specialty and we forecast it forward for the number of enrolled beneficiaries and so forth that we expect to have there in the future based upon where the Army says they're going to put their folks at. And so we use the historical utilization rates and the future population in order to estimate what the future need is going to be for each specialty at each location. On ancillary models, we do something very similar based upon weighted workload. So, you have weighted workload in the lab and radiology, and in pharmacy we use the number of prescriptions filled. The nursing care models on the inpatient side are based upon LIMS-I tasks and performance times. That's the workload management system for nursing internet, and all of our MTFs are using that. It basically identifies the nursing tasks that take place in each nursing venue and identifies how much time it takes to do that for each patient. And we sum that over the patients that are on those wards to come up with the staffing that is required on each one of the inpatient units, as well as in the perioperative area, et cetera. We have a nursing overhead model as well that addresses the overhead positions that, like infection control and things like that are not actually working on a ward taking care of patients. Other models are based upon workload and performance times, and let's go into some of the details here. Now, I want to give you a little bit of a history. What has happened in the past, we had Manpower surveys, we had joint healthcare standards, there was some benchmarking, we had 4 different versions of something called ASAM, which was the Army AMET staffing assessment model, and those were very useful for when they were done, but the ASAM model tends to be predicated upon population support ratios, and you'll recall that the new rules say that we have to use workload as opposed to populations. So even though we do use a population projection in our model, the bottom line is that it's not just the population, it is the population workload that is being looked for the model. So we've got
Hey folks, this is Sarah Ryan. Sorry to interrupt, Dr. Perry. Someone just joined and needs to mute their phone. Thanks.
Thank you. Okay, so the models that we're going forward with, they look at, as I said, the historical utilization rate and projected patient population changes. And that includes both the projected enrollment as well as the non-enrolled population. So all of the patients that are being seen at a particular MTF are counted in this utilization rate, not just the ones who are enrolled. And then we align the resources with population requirements for healthcare services. That's the goal. Now, the next two slides kind of depict the number of different models that we have had in the past. These were some of the ASAM models, and just to kind of give you, we would do a separate model for each one of these areas. And so when a hospital would say, well, we want you to update the model, that actually meant updating all of these models. And so and each one had a separate spreadsheet, a separate calculation of workload and so forth. And so this became very, very labor intensive in terms of identifying all these models. Anytime somebody said, oh, we want a model update for our MTF. What we have done now is, rather than doing these individual spreadsheet models, we are using the SAS program. SAS is a statistical application package that is used to process the data that is in the MHS data repository. So all of and the MHS data repository is what feeds the M2. And so when we go into the MDR, the way that you deal with the data in the MDR is, because it's a data warehouse, is you use SAS programming to manipulate that data and to do statistical transformations on it. So we use a SAS program that goes into the data warehouse to pull the data and do the processing in SAS on the mainframe, and then it spits out the spreadsheets so that people can, because we're all used to looking at spreadsheets and say, okay, I can see how the spreadsheet works and so forth. I like the data all lined up in nice little columns and everything. And so the output gets put out in terms of Excel spreadsheets, but the actual calculations and everything are happening in a SAS program that is programmed by our SAS programmer. So that's where we were in the past. We'll now address some of the new ones. Now, the inpatient nursing model was approved by USMA in July of 2010. Still good for a few more months, and we're about to get it applied to the TDAs this summer. It addresses requirements for inpatient nursing with the exception of labor and delivery. We're still working on the final details on labor and delivery. We'll get that up there pretty soon, but it's not quite ready yet. It has variable requirements determined by WIMSI nursing tasks for inpatients. And there are fixed requirements for head nurses, assistant head nurses, NCOICs, and ward clerks. So each inpatient unit is predicated upon the historical workload and a projection forward. Now, Captain Remolina, we have a question. Are workload and utilization review always historical? We have to rely upon the historical piece, but we try to project it forward to estimate what it will be in the future. And the idea there is that when we are having shifts, or let's say, for example, somebody has a business plan that an MTS says, I want to go recapture some particular line of business, or I want to open up an inpatient psych ward. We can use an estimate of what could be recaptured as well. So we have been asked to look, for example, when an MTF is going to do a recapture, we can include utilization from a number of different places. For example, it doesn't have to be MTF historical workload. It can also be historical workload from the network. So, for example, if we identify that we are going to recapture as part of our business plan 50% of the inpatient psych workload that has gone out into the network at this particular location, then that provides us with some utilization data that we can use to estimate what the manpower requirements would be going forward. And so we can use that workload as a way to do that. It doesn't, but it has to be documented somewhere. It's got to be somewhere in an authoritative data system. And the M2 and the MDR does provide us, on the medical side at least, with copious amounts of historical workload that has been observed either in the MTF or in the network that we can then use to identify a function that we're going to go after workload-wise and identify the manpower requirements associated with it. All right, let's see. I think that addresses the inpatient nursing piece. A couple of other questions. I'm seeing a question here from Ronnie Dawkins. Does the model consider the acuity of the patient population? The models do take that into consideration in terms of the RVUs on the outpatient side, and on the inpatient side, it is based upon nursing acuity, not on the physician acuity. So we'll get into that a little bit more in terms of how the professional services model is built, but Colonel Nagar says he'll send you a note as well. So let me move on to the next slide here. Professional services model. This is going to get to some of the questions that some of you have. This model is going to replace the primary care and behavioral health models, and it applies to all clinical specialties which generate RVUs. Okay, so any clinical specialty that has a clinic where they take care of patients and they document that care in such a way that provider work RVUs are generated in the system based upon the CPT codes and diagnosis codes that are documented in the record by the provider. This model will address the manpower requirements associated with that requirement. And this is the way it works. We use RVU productivity averaged over 36 months for each MTF and in each clinical area. And we divide that by the PBAM productivity goals, that's the performance-based acuity model, those productivity goals by clinical specialty and MTF. So for example, there is an RVU productivity goal associated with each clinical specialty that says that if a provider is operating in the clinic, they should generate for that particular specialty a certain number of RVUs per day in the clinic. So what we do is we take the productivity averaged over 36 months divided by the goal, and that tells us how many clinical FTEs are required in that particular specialty at that location. It doesn't matter what clinic they operate out of. So for example, you could have a psychologist working in a patient-centered medical home, and when they document their care, there is a provider specialty code that is part of their CHCS template that identifies them as a psychologist. And all of the work that that psychologist does will be stamped with that psychologist provider specialty code. And so we will identify all the work that is done by psychologists at that particular MTF, divided by the workload goal, and that will generate the number of FTEs that are required to do the clinical workload at that location by specialty. Now, the RVU productivity goal is based upon an MGMA ratio of productivity goal, but it is adjusted for the availability factors of military and civil service providers in the MHS. Okay, so we understand that not everybody is available in the clinic 8 hours a day, and certainly not 365 days a year. So it is adjusted to reflect the idea that our providers are supposed to be available on the average 1,740 hours per year, which is about 240 some odd days, I think. So that productivity goal starts with MGMA. We adjust it somewhat to account for availability, and then we add in the amount of FTEs that are documented in Demer's Eye for non-RVU generating provider activities. This could be administrative time, it could be GME, it could be readiness time, it could be inpatient rounds, it could be time spent in the OR, it could be anything where the provider says, I'm not in the B account clinic today or at this hour, I'm doing something else. Now, we have been able to convince USAMA to use this amount of time as a proxy for the amount of work that they are doing that doesn't necessarily generate an RVU or any other type of measurable workload necessarily. So we use the time generated and documented in non-B account, non-members B account areas as a proxy for the amount of work that is being done there. We add that together to come up with the total number of FTEs for providers that are required at each specialty at each MTF. Now, once the commanders get those FTEs, the commanders then task organize those requirements into the clinical work centers for patient-centered medical home, community-based medical home, EBH, soldier-centered medical home, specialty clinics, etc. We also add in the clinical support staff associated with front office operations and clinical support for each clinical specialty for the workload that is generated in the clinic. Okay? So I want to differentiate. You get clinical support staff and front office support for the clinic workload, not for the non-RVU generating workload. So, for example, if you have a department chief who is writing evaluations or OERs, you don't get support staff to help you write the OERs. You write those on your own. Same thing with readiness. When you go to the firing range, you don't get the support staff to go help you pull the trigger. You do that all by yourself in the foxhole. When you go to the inpatient side and do inpatient rounds, you don't take the clinic support staff with you. You rely upon the nursing staff on the wards to go with you on the patient rounds. And so that clinical support staff that is in the clinic stays in the clinic and it's available to help the providers when they are seeing patients, and that's what they're there for. You don't take them to the OR with you either. There's nursing staff and anesthesia and so forth that is in the OR to help you out when you go to the OR. So that's kind of the way the professional services model works. Now this slide kind of shows some preliminary results. These are a little bit, these have been they're in the process of being modified with the final tweaks that were made to the model, but this kind of gives you an idea in terms of the overall magnitude of what we're talking about. So if you look at the top one there, it's got family practice, and there are roughly 651 RVU-based FTEs across the MedCom where this is predicated upon the clinic work that's being done by family practitioners. And the family practitioners include the family practice docs as well as PAs and nurse practitioners who are working in family practice clinics specifically. And then there are some non-RVU-based FTEs, this is admin time and things like that, of 201.9 FTEs there. We add those together, you get 852. If you round it, and if you round it at each MTF to make sure that you have full people, then the provider requirements actually don't come out to 853, but 855 based upon the actual rounding algorithms at each location. So it's not, you know, these are summarized across the entire MedCom, so the rounding doesn't look like it's exact here because it's actually rounded at the MTF level rather than at the aggregate level. We then add in the GME requirements because this is for trainees, not for the teaching staff. Generally speaking, we will look at each location, and if there is enough teaching staff generated by the workload, then we don't add additional teaching staff to it. But there are GME requirements for 121 residents for family practice. We add that in, it comes to 796 altogether, and then you have the support staff requirements of 2,260, then you add those all together. So that's kind of the way that the model works. We went from, this is kind of sorted from top to bottom in terms of the size of the specialty. You can see the hand surgery is down there at the bottom. Don't have a whole lot of those particular positions out there. And this also does not include Walter Reed at this particular point since we don't own that particular TDA. So these are just for the MedCom TDAs. So those are some preliminary results, and we have documented this, and we've taken the results to several of the facilities to validate, you know, what it looks like. We went to Fort Hood, we went to Launch Stool, and we went to Fort Bragg. Each of them had a few different issues with the model, and we're working on tweaking those things to try to get the model to fit just a little bit better. But by and large, we think it's pretty accurate. At Fort Bragg, or at Fort Hood, it turned out that this was almost exactly spot on with what they actually had on the ground with regards to the number of people they had in each clinical specialty. Now, so we've talked about nursing and we've talked about the clinical side. I want to address, this is kind of a way forward. So you'll recognize that in some of our administrative areas, it's really hard to measure the amount of workload that happens there. So for example, if you think about the resource management field, how do you measure the amount of work that happens in resource management? I mean, do you just say, well, we'll give you 3 people for every $1 million that you have to manage? You know, it kind of defies description, and we don't have work products in terms of, you know, patient care visits or things like that. But we sort of have a feel that if a hospital is bigger, it probably needs a bigger resource management division. And if it's smaller, or even a clinic, maybe it doesn't need one at all. And the work can be handled at the parent level organization. So we've been looking at a number of the other ratios that MGMA publishes, and one of them is something called back office support staff. And so we started looking at that number and at the support staff that we have within the MTF at Administrative Services, and we kind of came to the idea the other day that we can probably document almost precisely the number of requirements for things like patient administration and resource management and human resources, managed care and clinical support divisions from this back office support staff ratio at each MTF. And if we apply that to each of the clinical specialties and then add up all the back office support that is required for the entire MTF and all the clinical work that goes on there, and then allocate those positions on a percentage basis, you know, what percentage generally goes to RM, and what percent generally goes to PAD, and so forth, in terms of their current staffing out there, we have a feeling that this is going to work pretty well. So this is one of the things that we're going to be doing over the next couple of weeks is identifying what the implications would be if we apply this kind of a model, because we have not been able to get real good handle on how big does an HR division or a RM division or a managed care division really need to be, because the workload that they produce is not really, it's not very measurable, and even the division chiefs have a hard time figuring it out. You know, IT is a little bit different. We can count the number of IT work orders and help desk support requests and all those kinds of things, and you can kind of measure that, the amount of time it takes to handle those. Same with logistics, but with some of these management, you know, business office kinds of functions, it's a little bit more difficult to measure. So we're going to be looking at this as a way of doing this going forward. We also have some dental models which are about to be applied to the TDA. We have a briefing tomorrow to headquarters DA to get the approval to apply the dental models. And the dental model requirements are based upon observed treatment times associated with various dental treatments and the need for those treatments within the military population as documented in annual dental examinations. So the military out there understands that every year you get an annual dental exam, and they say, okay, we got to take care of this, and this. And sometimes they have time to take care of it, and sometimes it just kind of falls to the wayside, and it gets documented again the next year. Hey, you still need to have this molar taken care of or whatever. And so what the model does is it will base the dental officer requirements based upon the amount of care that is required, that is documented on the annual dental exams. And that gets put into a system called the corporate dental application, and it's identified at any given point in time how much care is out there that has not yet been addressed. This model also includes enough dental hygienists to provide for the ADA standard of 2 dental hygiene appointments per soldier per year, and enough dental assistants to provide 1 assistant per dental operatory, plus the radiography and dental laboratory and reception and management oversight. There are separate requirements in there for the dental graduate education as well. So question came in, how are the call centers allocated authorizations? So this is addressed through the clinical support staff. If you think about the way that there was a number of years ago, we had all of the appointment clerks and so forth were handled at the clinic level. And then we sent something out in the field and we said, we want you to use a centralized call center. And so with these particular issues where you have a central call center, those requirements are part of the clinical support staff and front office support requirements that are generated per specialty there. And so they can be merged together to create those call centers. And so you might not actually have all of those people working in a clinic. It may be working at a call center where they're making central appointments and things like that. But it's still aligned against the clinical workload in each of the specialty areas. And let's see. If you have overhires, the definition of an overhire is actually when you have hired somebody against a requirement where there's no authorization or against a place where you don't even have a requirement. So that's the definition of an overhire, and that's a faces issue as opposed to a spaces issue. So if you have more faces on board than what you have in terms of the spaces, that's the definition of an overhire, and to the extent that those overhires are productive, they will generate new requirements in the future. If they are not productive, then they will continue as overhires for the long run. Moving to the next slide, here's some examples of what the dental model will look like. And so you can see out there on the right-hand side, the Dentech headquarters. You know, we kind of rolled this up at the RDC level, you know, for Europe, North Atlantic, et cetera. Those are the number of requirements. You can see it's got, you know, positions for the Dentech commander, the XO, the senior dental NCO, et cetera, credentials coordinators. A lot of those are templated. If you look down below where it says the dental clinic model, this is where the pink cells there, you can see what the workload is, the population. We look at the number of dental treatment, DTR is dental treatment rooms, the number of clinics and so forth. This helps generate the number of dentists, the number of dental assistants. You'll notice that the dental assistants chair site is equal to the number of DTRs. So those are one per. Hygienists are based upon the number of the population supported and doing the dental hygiene appointments of 2 per soldier that's in the population there. And you'll notice that the population there is 656,000. That's a little bit more than what is in the Army. That is because some of our dental activities actually take care of other service personnel as well. And so we incorporate all of the active duty military that we care for, not just the Army folks. Okay. That concludes the formal part of the presentation. I'd like to open it up for questions at this particular point. Here is a question: how will VERA, VSIP, and RIFs impact the TDAs? This is again a faces issue, but let me tell you what will happen when we have requests for VERA, VSIP requests from the civilian staff. There are 2 different ways that supervisors can handle those requests. VERA, VSIP requires that the position on the TDA be either restructured or eliminated. Okay, so the supervisor can restructure a position in terms of the grade or the series of the individual in the position, or they can eliminate the position as a way to if they want to approve the VERA VSIP, but they have to do one or the other. So in the case, let's say we have a physician who is a civil service employee and wants to do a VERA VSIP, and let's say that they are a family practitioner. Well, let's see, we still need a doc there. Let's say, assuming that they still need a doc there, well, maybe they can use an internist instead. However, for physicians, they're all 602s. Well, let's see, what else could we use? If you still need a provider, well, could you use a PA instead of a physician? That might be one way that you could restructure it. Or if the position is a grade 14 and you want to make it a grade 13, or it's a 15 and you want to make it a 14. Any of those things, if you change either the series or the grade or both, will allow the supervisor to recommend approval on the Vera VSIP application. The way that you then get that documented on the TDA associated with the Vera VSIP application is to submit a copy of the approved PD in the new series and grade to the Manpower folks, and then they will forward it up the chain to us, and we will request the change on the TDA to headquarters DA based upon the changed series and grade on the Vera, from subsequent to the Vera VSIP. Now with RIFs do not change the TDA. A reduction in force action will take place, if it does take place, let's say that and this is an HR issue, it's not necessarily a Manpower side, but let's say that you identify 25 people at a particular installation, at a particular MTF that are going to be RIFed because they are in over-hire positions, perhaps. Okay, I'm not saying that that's going to happen, I'm just saying let's do a what if. So if that were to happen, and you identified 25 people at a particular MTF who were excess to the needs of the organization, it doesn't necessarily mean that those particular folks would end up without a job at the end of the day. What would happen is there are several stages of a RIF. The first people who would be identified ostensibly might be people who were in over-hire positions who did not have authorizations against the job that they were in. But they may have seniority over other folks, and so it gets into the bump and retreat rights of civil service employees, and as well as, so the retreat rights mean that they can retreat to any previous job that they have held, that they're assuming that they would assume to be qualified to hold it because they had held it before. And they could then knock somebody out of a job that they previously held because they have retreat rights to that job. The other way that they could keep a position at the MEDAC or DENTAC would be is if they bump someone to whom they are senior and that they are also qualified to do that job. And so they could bump someone from a more junior person out of their job, then the initial person gets the job that somebody else is in, and then that person gets put into the RIF pool, and then they could potentially either bump or retreat somebody else and so forth. And so what ends up at the end of the day is you end up with people who are bumped out of their jobs and have no place to go, and they tend to be more junior folks within the organization. And so that's sort of the way that happens, but this is, again, an HR function as opposed to a Manpower function. The TDA might serve as the basis for identifying which positions are excess and who is first up in the bump and retreat process of a RIF. Okay. Let's see. How will preventive medicine, which has RVU and non-RVU requirements, be calculated? Again, preventive medicine is, to the extent, it's kind of like, if you think about anesthesiology. Anesthesiology spends most of their time in the OR not generating RVUs. And a very small amount of their time in the anesthesiology clinic and in the pain clinic dealing with some pain issues and preparing people to get ready for their surgery and so forth. In terms of asking them questions about their anesthesia and allergies and so forth. So it's a very small amount of RVU time for anesthesia and a large amount of non-RVU time. The same thing would be true for preventive medicine. If they are spending most of their time doing activities that do not generate RVUs, they need to document that time in the non-RVU generating work center, and that's how their time will be accounted for. There are also some other areas. So, for example, people might ask questions about, well, what about when we're doing our SRPs and we're out there trying to get soldiers ready to deploy and so forth? That time that the providers spend doing SRPs should not be counted as B-account RVU generating time. As long as they account for their time in the work center taking care of the SRPs, then they will not be placed at a disadvantage TDA-wise. And the same thing could apply to things like doing narrative summaries for MEBs, any of that other non-RVU generating work. They need to make sure that they account for that appropriately in Temper's eye as opposed to counting it as, well, I'm sitting in the clinic.
Yeah, well, the question is, what happens if the ward is removed as an ETF, part of the RIF? What happens to the authorization? So, in case of RIF.
Okay, well, if we have a RIF, again, it's not necessarily directed at a particular ward, but let's say that the nursing model identifies that a particular ward needs to be merged with another ward or eliminated because it doesn't have enough workload to justify the staff. Or the commander decides that they're going to merge things together and create one ward out of two and use the space for something else that the other ward was in. So what will happen in a case like that is if the nursing staff is going to be decremented, the MedCom has been long averse to creating RIFs, and the RIF requirements are such that you have to notify Congress and so forth and get approval to do that. And so we have not generally been willing to do it in the past, and I don't know if we're going to be able to do it in the future. But again, I described the process for the RIF, and this is an HR process as opposed to a Manpower process. If, however, we're going to merge inpatient units, for example, we would use the Manpower requirements from both units together to validate the requirements for the merged unit. And so, for example, if you had two small units being merged together, and what you would probably keep enough positions of the 24/7 staffing side, and then it would be the overhead positions that might be reduced in terms of the, if you're going from 2 units to 1 unit, you don't need 2 head nurses anymore, you need 1 head nurse, et cetera. And so to the extent that those positions and the authorizations would be made available, the authorizations can be moved to another part of the organization where there is an unresourced requirement. And so that's what we try to do usually, is to move those authorizations within the organization to another parking space, so to speak, that is at that particular point not being used. So we try to keep those authorizations at all costs, whether they're military or civilian. I have a question on telemedicine workload. How are we going to capture it? Telemedicine workload, if it should be accounted for using the patient record, and if the workload is accounted for with the diagnosis codes and procedure codes, then it will result in RVU workload, or at least it should. And so, to the extent that the documentation is placed in ALTA, then telemedicine can be used as a way to justify Manpower requirements associated with that as well. But again, it's about the documenting the workload and documenting the care that takes place. The same can be true to a certain extent for telephone consults and so forth. As long as the workload is documented, we can take advantage of that. To the extent that it is not documented, then it results in a loss of time and loss of manpower requirements. On this particular line, there's also a question that somebody might have about, well, what about the proactive calls that are made from the patient-centered medical home for chronically ill patients or patients with diabetes and so forth, where the PCMH staff is making proactive calls to make sure that people are doing their testing and coming in for their A1C test and things like that. Those proactive calls, the workload associated with that is associated with managing the population that the PCM and the support staff collectively manage in terms of the enrolled population or the impaneled population for that PCM. The idea is that those support staff are there specifically to do that additional work, that the PCM is not necessarily going to be making those calls. We understand that, and that's why the nursing staff and the PCM support staff are there, not just to handle the patient's processing through the clinic, but also to handle the proactive measures that have to be done in order to maintain a healthy population. Colonel Nod is writing down another question.
Can you talk about command line and manpower programming?
Yes. Command plan and manpower programming happen at least once a year. We have what we call a regular update, which is when we roll over from one fiscal year to the next fiscal year, and we create the 01 series TDA, which is like the 0114 or the 0115. Now, this command plan, we send out instructions to the field, to the manpower analysts at the RMCs and the major support commands and so forth, and to the MTS about any particular changes that are going to be taking place as part of the command plan. So, for example, what has gone out recently for the fiscal year 15 command plan is a discussion of, well, it's going to be going out, is a discussion of the idea that we are going to be losing all of the unresourced requirements, and they will only add them back in. Headquarters DA will only allow us to add unresourced requirements back in if they're based upon newly approved models and concept plans and studies. And so this occurred in part because of a number of years ago when Headquarters DA decided that all of our manpower models, which were then based upon population ratios, were no longer valid, and we had to replace them all with workload-based models. So as we get through this process, they became dissatisfied with how much time it was taking to do this. And so they said, well, we're going to give you an extra incentive by simply taking off everything that's old and stale, that it's not resourced or is not based upon a new model. And so this is one of the things that they've done, and they get to make the rule, and so we just have to deal with it. But those are some of the things that come out of command plan. Again, this is where we will let the commands, the MPS know about changes in their authorizations. We will look at also reductions to the extent that we are being told that there are reductions or increases based upon grow the Army or shrink the Army. This is where a lot of those will take place, is in the annual TDA updates in the command plan. Do models account for multi-service market demand? The models account for all of the demand that takes place in our MTS. So, for example, if you go to San Antonio, what we did with the merger between Wilford Hall and BAMC, not really a merger, but the inpatient workload from Wilford Hall has been shifted in large part to BAMC. And so what we started off with was looking at moving all of the inpatient manpower requirements from Wilford Hall over to BAMC, and saying, okay, that's what's going to move. But as it turns out, the Air Force didn't quite like it that way. They said, well, we're going to send some of our outpatient people and some of our inpatient people, and so there was an RMD, a resource management decision, or resource management decision that was published that identified how many manpower requirements would be moved from Wilford Hall to BAMC. And so those requirements and authorizations have been moved and will be documented shortly on the BAMC TDA. And so the civilian requirements will be changed from Air Force civilian requirements to Army civilian requirements. And the Air Force manpower will be documented both on the Air Force's TDA and as non-ad, it's kind of like borrowed military manpower on our TDA. So the Air Force will maintain authorizations and requirements on their side, but we will depict the number of Air Force requirements that get added to our TDA to do some of that work, and those Air Force requirements will, in part, count against the workload that is generated at BAMC. In other areas, the multi-service market area, again, we only document for our MTS the amount of workload that takes place within the walls of our facilities or is planned for production within our facilities. Industrial hygiene requirements. Okay, industrial hygiene is one of those areas that has not yet been modeled, and we will address that in the coming months, but we have not got that yet. Again, this is one of those models that it's not really an RVU generating piece, and so as the industrial hygiene folks are out doing inspections and addressing the work centers that they deal with. We've got to find a good way to measure that workload so that we can model and validate those requirements. But right now they are not being validated, so they are being left alone until such time as we can figure out what to do with them and how to appropriately validate them. Okay. If there are other questions, we've got about 15 more minutes. If there are other questions, you can email them to either Colonel Nagra or myself, and we will answer those as well. Next week we'll be getting together again for a follow-up session to answer questions. If there are no other immediate questions, let me turn the time back over to Sarah.
Thanks, Dr. Perry, and thank you, Colonel Nagra. That was great. I think we had probably about 120 or so participants on the line, so certainly a topic that people are interested in hearing about. As Dr. Perry mentioned, we'll get together at the same time next week. I can tell there's a lot of questions out there, so please feel free to bring any remaining or new questions next week. That's May 2nd at 1300 Eastern, and Dr. Perry and Colonel Nagra will help answer those. We'll use the same DCO login, and there's a new telephone login or dial-in bridge that I will send out to folks as a reminder. We've recorded this session, and in the next couple days I'll get it up on our YouTube channel. So if you missed this, or if you have colleagues who would like to view it, they can check out the recording on our YouTube channel. The slides that Dr. Perry presented today are available in the file share. You can download those. Just look out for the pop-up window. You can download them and save them to your computer. And finally, I put the link to a post-course evaluation in the chat pod. Please just take about 5–10 minutes and take that post-course survey. It helps us improve our presentations. And you can also submit questions there, and those will be some of the first that Dr. Perry and Colonel Nagra answer next week. So you can ask your questions in advance. Some upcoming courses, so you can plan ahead. On May 9th, we'll do a session on secure messaging. And then at the end of May, on May 23rd, we'll do an overview of resource management and funding streams within the MedCom. So look forward to those. With that, thank you for joining us today, and we'll look forward to having you on the line next Thursday as well. Thanks again, Dr. Perry and Colonel Nagra.
Thanks, everybody. We appreciate your participation.